the septal occluders need to permit, the occluders need to permit septal recrossing. So, you know, let's see, make sure the slides move. I have no disclosures for this talk. We know that there's increase in device occlusion of the interatrial septum with proliferation of ASD and PFO devices. We know that now with the new indication for PFO closure, we see more and more devices being done. But we also know that there's a continued increase in transcatheter techniques and procedures utilizing the interatrial septum. You know, the IAS is the gateway to the left atrium for a lot of our procedures now. This involves not just interventional cardiology, but also electrophysiology. So as we put devices in this part, we have to be cognizant of that we may have to come back and get back into the left atrium. This is just the anatomy of the interatrial septum as seen from the right atrium. We know that the main site is usually fossa ovalis. Now, if you put an ASO or ASD closure device here, you're basically taking that fossa out of the picture for reassessment later. Now, if you do put a PFO device, it's usually a little more anterior and superior, and you sometimes can get back below the device. So depending on what device you put in the interatrial or in the interatrial septum, it can make or break interventions in this area. Now, this is a slide, a diagram that shows the puncture sites for some of our more common techniques. We know that when we're doing a mitral clip, we want to be superior and posterior. We know for the Watchman or left atrial occlusion devices, we want to be inferior or posterior. If you're doing a simple access through into the left atrium for hemodynamic measurements, or if you're doing a tandem heart, you probably want to stay right in the middle of the fossa. And for pulmonary vein interventions, you probably want to be a little more anterior. So, you know, the sweet spot is somewhere in the fossa, and once you have a device in that area, it can be pretty challenging to get back in. So what are the case scenarios? You know, this is something that the EP guys have dealt with for several years, because they will usually come back after someone has had an ASD closure to come and try and manage their atrial arrhythmias, AFib, atrial tachycardia, things like that. So there's enough data from the EP side of things to show that they can maneuver through these devices. Now we see more of the transcatheter mitral interventions where we have to come back and do a mitral clip or something similar. Obviously, left atrial appendage occlusion. If you have to put in a support device that needs an LA cannula like the tandem heart, or you just want an antegrade access to the left ventricle for devices. So there are several publications, usually case series, showing the capacity or the ability to cross these devices. You can either walk around them or go through them. So there's several. A lot of them have been in the EP arena. More recently, we've seen some in the structural heart arena as we start facing this challenge. So what are the current techniques that we can use? You can go posterior and inferior to the device in the native septum if you have enough space. You can all go very superior and posterior to the device if you have enough room. Or if you don't have enough room in larger devices, occluding the entire interatrial septum, then you got to go through the device, and that can be challenging. So this is a picture of a device where we've gone through an amplified septal occluder for an electrophysiological procedure. You can see that the sheath is going right through the device. That can be achieved. And these are movies that show a patient with a PFO, and there was enough space below the device for catheters to be put into the left atrium. So in case of PFOs, it's usually not an issue, but when you have a large ASD, that can be a challenge. These are still frames of the same thing. We have an amplified PFO occluder here, and you have tenting of the native interatrial septum, and you can see the sheath going through that and avoiding contact with the amplified device. This was a case that was presented in JACC where there was an attempt to do a left atrial appendage occlusion with a large interatrial septal device. And you can see the steps taken here is you have to cross the device, you have to do extensive balloon dilatation, of the device and then occlude your appendage, and then when you're on your way out, you close the hole that you've created within the device and come out. So, this is a lot of steps to, get a simple left atrial appendage occlusion done, but sometimes that's what you have to do. Now, with this kind of techniques, there are always consequences. You can dislodge devices. In fact, some of the recommendation is that you don't want to go through an ASO device within the first 6 months of closure. So usually want at least 6 months to allow the device to kind of endothelialize a little, get seated well before you start poking around that. You could damage the device to an extent that it's now not very useful. It may be difficult to maneuver or torque your devices in the left atrium. You could cause cardiac perforation or tamponade. I know Paul showed a case yesterday of trying to get across an ASO device, and initially it wasn't found by the TE imager because it was really posterior, and if it had persisted, it would have been in the outside the left atrium. So this can be really problematic, and obviously increases your procedure and fluoroscopy time. So that's a challenge. This is what the devices we have in the US. You still have the PF4 Occluder, you have the ASO Occluder, obviously the Gore cardioform device. All of them can be perforated, some easier than others, but they can all, you can get through most of these devices if you persist. So in conclusion, to answer the question that Paul has posed to me, do they need to permit septal recrossing? The simple answer is yes, but it's always yes with a caveat. Usually, I would say that for ASO devices or devices that occlude ASDs, yes, you want to have some device that you can go through easily without a lot of force. It does give us allowance to get a transseptal route open for further interventions down the road, but obviously requires design modification. That means you got to get new devices, you got to go through the approval process. So this is something that's going to be time and financially consuming, and also it requires material modification, because now you've got to design materials that will allow passage of devices without leaving a big hole at the end. So I think if industry is in the room, I think this is an area that may be financially viable as we look into new devices for interatrial septal defects. It would be nice to have something that allows septal recrossing for future interventions down the road. Thank you for your attention.